So thank you, Chairs. First of all, I would like to apologize on behalf of Bianca because she couldn't attend the meeting this year because of unfortunately personal reasons. These are my disclosures.
We've got
the wrong slices.
Yeah. There we are.
That looks better. Thank you. So I have nothing to disclose, so that's easy. Stress urinary incontinence, many of them are treated with a surgical treatment. Also the mid-urethral sling, and we have the transobturatory and retropubic TFT. But also a lot of these stapes need to be removed. We see removal rates of about 3%, and also a lot of pain, and especially the pain without any cause of erosion or exposure is difficult to treat and challenging. So we have some strategies to treat them, from conservative to surgical. And the aim of our study was to evaluate the results of our removals of these slings in women who have pain as the only single complaint, so no exposure or erosion. So we selected the patients who underwent a partial or complete sling removal for pain from November 2004 until June last year. And we did a retrospective chart study, and we also sent a questionnaire to these patients. And the primary objective was pain, so the pain response preoperative to the current pain. And we did that by the questionnaire. And the secondary outcome, there was recurrence rate or increase of incontinence. And we tried to look at predictors for poor outcome of these MUS removals. So we had 31 patients, and 26 questionnaires will fill out totally and send back. And these are the results. Pain was most of the times pain was at multiple sites. And it was a bit to the surgeon whether to remove the tape totally or partially, or do it in one stage or more stages. And all variants of surgeries were done. Eventually, a quarter of patients was pain-free, so they had a VAS score of 0. And for the other ones, the VAS dropped significantly. But on the contrary, the incontinence increased, of course. And it's quite a lot of people, 79%. But it unfortunately didn't ask whether it bothered them or not. And yeah, not all of these patients did have other interventions to treat their stress urinary incontinence afterwards. For the predictive factors, unfortunately, we had 2 less patients to really analyze them. So for the conclusions, pain after MUS is invalidating, and a partial or complete removal solves the pain in a quarter of the patients, and in the other ones a decrease is possible. But of course we have on the contrary the post-operative increase in stress urinary incontinence. But at least in the counseling we need to mention the surgical removal as an option, besides only the long-term treatment with pain killing, which also has its adverse events. So counseling is very important, and we should suggest at least that you discuss the option of surgery. So thank you for your attention.
I have a question for you, which you may not be able to answer because you did a retrospective chart review. Yeah. But how many of these patients had a preoperative pain syndrome or fibromyalgia? Because I think that many of the patients who develop pain after a tape insertion already had pain before they had it inserted.
Yeah, we did ask for fibromyalgia, but it was actually that in this group, to the contrary, which is normal, that they did better. So it was a little bit unexpected, but...
Gamal.
Gamalgunimi USA. Great work. You know, there are a couple of things I want to ask about. The timing has any relationship to outcome? And the other question is, when did you decide to do just incision versus one arm versus trans or suburethral versus all vaginal? Obviously, the groin, you know, that's self-explanatory.
Yeah.
So in your vaginal approach, how you decide to do that?
Yeah, of course, there's been many surgeons throughout the years. For my own clinical experience, I always start only by resecting one part or where the most pain is, and the relief of the tension solves most of the times the problem. So I don't remove the tape totally in the first stage, also for the incontinence later on.
Okay, you have a very high incidence of recurrent incontinence.
Yeah, and recurrent incontinence or an increase in incontinence.
Yeah, yeah. It's a little bit different than other series.
Yeah.
Any explanation for that?
Probably because most of these patients come from elsewhere to our center, and it is already quite a long time ago. We don't see these patients anymore that they hopefully are more honest.
Okay, thank you.
Thank you.
Yes, hi, Ida Bergman from Stockholm, Sweden. Thank you for a very interesting study. I was just wondering, because this was retrospective, how did you collect the VAS score preoperatively? Was it
Retrospectively,
recalled by the patient?
We had two less that they really asked it before surgery, so we had to ask it by the questionnaire.
So they recalled the pain?
Yeah, recalled it. Yeah.
Okay.
So the most trustable number is the quarter of patients who are pain-free in the end.
So I have a particular interest in the groin aspect, and I'm just curious. I know the numbers were small, but did you break it out and see what % of those patients had improvement? And I'll tell you the reason that I'm asking that after.
No, not yet.
Okay, because I think that would be interesting. Initially, when we did a lot of these, I had a lot of patients who had improvement, and since then I've had a handful where they didn't have quite that improvement. So I think the more people specifically look at that issue, it would be helpful.
Yeah. Now, most of the times I resect the tape on the side where the pain is, and also in the groin. And we couldn't get out of the numbers that it was really like you need to go to the groin or just resect it vaginally. The numbers were too low. Yeah.
Canada, I'm wondering what investigations women had prior to removal to confirm that pain was the only symptom, because often pain goes hand in hand with other voiding.
Yeah, so patients with an erosion or an exposure were excluded. So
But
only,
what about voiding dysfunction? Did you
no,
assess?
they were also excluded. Yeah.
There's a big controversy about how much tape to remove.
Yeah.
Now, in the patients who had complete resolution of pain, did they have a more extensive dissection, or do you think it was basically even resolution occurred with a minor dissection? Because this is becoming a big problem.
Were not all the ones who were totally removed, or that a more complete removal would resolve the pain more often than in the ones who we did partially. But I can't say to the contrary that partially removal will do better than totally removal, because we also end up with slice technique in several stages.
Was the success rate related to the type of mid-urethral sling? I mean, is it more easy to resolve pain in patients with a retropubic rather than the transobturator? It would be, because this transobturator is much more difficult to access and to excise the entire mesh. I mean, the part outside the obturator is almost impossible to reach.
Okay, I have another experience with resecting the tapes. The transobturator tapes can as easily be removed as the retropubic tapes. But there was not really a relation to which tape solves the pain best by removal. Okay, thank you.